A patient presents to the emergency department with a classic acute coronary syndrome. They have ischemic chest pain, an upward trending troponin curve, and distinct ECG changes. Ischemia is a condition where blood flow and oxygen to the heart muscle are severely restricted. For decades, the standard protocol has relied on a strictly mechanical view of the heart. The physician naturally assumes that a ruptured atherosclerotic plaque has caused a flow-limiting clot in a major artery, and the immediate next step is an angiogram to find the blockage. Then comes the clinical paradox. The patient undergoes angiography, but the scan reveals widely patent vessels. There is no obstructive stenosis, or narrowing, anywhere in the visible coronary tree. Historically, this exact presentation resulted in widespread clinical dismissal. Patients, and a disproportionate number of these patients were women, were frequently misdiagnosed, discharged without secondary prevention, or simply told their heart was fine because the pipes appeared clear. Modern cardiovascular science corrects this error. The strict definition of an acute myocardial infarction requires evidence of tissue ischemia and cell death. It does not strictly require a persistent and dangerous misconception is that a MINOCA diagnosis implies completely normal or plaque-free arteries. MINOCA explicitly includes patients with mild to moderate atherosclerosis. The defining criteria is simply that no single lesion meets or exceeds the 50. Troponin is a protein complex released into the bloodstream when heart muscle is actively damaged. This first pillar is designed to isolate ischemic mechanisms. It explicitly rejects non-ischemic causes of myocardial injury, ensuring the diagnosis is centered on a true loss of blood flow. The second filter is pillar 2. The patient must have non-obstructive epicardial arteries, pragmatically defined as less than 50% narrowing on a standard angiogram. The final filter is pillar 3. Clinicians must actively exclude overt alternate diagnoses and systemic mimics. Presentations like sepsis, pulmonary embolism, myocarditis, or Takotsubo syndrome can elevate troponin but are entirely separate conditions. Only after a patient passes successfully through all 3 of these pillars are they officially assigned the working diagnosis of MINOCA. MINOCA is never a final label. It is a meticulously filtered starting point that obligates the physician to find the hidden cause. The central clinical dilemma immediately follows. How do you identify the cause of an infarction when standard cath lab tools only visualize the unobstructed lumen, or empty space, inside a blood vessel? The solution to this limitation was demonstrated by the Women's Heart Attack Research Program, or HARP, a pivotal multimodality imaging study. This split-screen model contrasts the two approaches. The HARP study deployed a dual imaging protocol. It used optical coherence tomography, a technique using light to capture micrometer resolution 3D images of the coronary walls, alongside cardiac magnetic resonance imaging to characterize the actual heart tissue. Optical coherence tomography maps the microscopic internal architecture of the artery. It easily detects plaque surface disruption, microscopic thrombi, and subtle tissue tears that the flat two-dimensional angiogram completely misses. A libely misquoted statistic from the HARP study claims an exact 46% rate of plaque rupture in these patients. This is a misinterpretation of the data. HARP actually reported that 46.2% of patients had an OCT-identified definite or possible culprit lesion. A culprit lesion includes various types of physical damage to the vessel wall, not exclusively a ruptured plaque. When both advanced imaging methods are combined, the study proves that a likely ischemic mechanism is successfully identified in 84.5% of MINOCA cases. These cases are not medical mysteries. The mechanisms causing the infarction simply exist at a resolution that legacy tools cannot perceive. When high-resolution imaging protocols are applied, this radial menu illustrates how the singular umbrella term of MINOCA fractures into 5 precise mechanistic pathways. Mechanism 1 is plaque disruption. A mild plaque, well under the 50% threshold, ruptures or erodes. This triggers a temporary blood clot that causes the infarction, but the clot dissolves or travels downstream before the angiogram is taken. Mechanism 2 is coronary vasospasm. The smooth muscle in the epicardial artery intensely constricts, cutting off blood flow long enough to cause cell death and then relaxes. Mechanism 3 is coronary microvascular dysfunction, or CMD. This involves impaired regulation and restricted flow within the tiny intramyocardial blood vessels, which are completely invisible to standard cameras. Mechanism 4 is coronary embolism or thrombosis. A clot originated elsewhere in the body and travels to the heart, causing distal microvascular occlusion with minimal epicardial disease left behind. Mechanism 5 is SCAD, spontaneous coronary artery dissection. The inner lining of the blood vessel violently tears away from the outer wall. Blood pools between the layers, creating a false channel that bulges inward and chokes off the actual vessel. SCAD is a critical non-atherosclerotic cause of infarction. It is highly prevalent in younger women and requires high clinical suspicion to detect, as its angiographic appearance can be extremely subtle. Each of these 5 mechanisms involves a distinct pathophysiology. Consequently, treating MINOCA as a single, uniform disease state is clinically impossible. A dangerous assumption persists in clinical practice: the belief that a non-obstructive angiogram guarantees a benign prognosis. The data proves otherwise. This action registry line graph plots long-term MINOCA outcomes. Patients face escalating risks of recurrent infarction and mortality. While lower than in extensive obstructive disease, the absolute risk baseline for MINOCA remains unacceptably high. Historically, inconsistent diagnostic definitions merged entirely different diseases together, which masked the true danger of the syndrome and yielded conflicting prognostic estimates. Discharging a MINOCA patient under the false reassurance of clean arteries leaves them exposed to severe recurrent ischemic events. Determining the optimal treatment path is challenging because legacy heart attack trials systematically excluded patients who did not have obstructive coronary artery disease. Today, management relies on large-scale observational data, like this Sweetheart Registry diverging bar chart. Statins and RAS blockers show strong associations with improved long-term outcomes. Conversely, routine dual antiplatelet therapy shows no clear overall benefit across this heterogeneous group. The traditional mechanical model of coronary disease is obsolete. MINOCA is a verified, high-risk ischemic syndrome. A non-obstructive angiogram in the presence of infarction criteria is no longer a reason for diagnostic dismissal. It is a strict clinical mandate to utilize multimodality imaging and locate the exact mechanism of the invisible infarction.